My name is Phillip Westbrook. I have the privilege of being the Chief Medical Officer for Ventus Medical, and I'm just going to give a very brief preview. And then we have Dr. Meyer Krieger, whom many of you know or know of. He's going to talk about possible practice parameters for Provent. A Dr. Glenn Adams, who will talk about the actual use in a clinical practice of pulmonary and sleep medicine. Kendra Becker will talk about the use of Provent in the practice at Kaiser Permanente, and then Paula Schweitzer is going to summarize some of the clinical data we have and look at prediction of response. I think you're here because you realize that we need another treatment option. Up until the 1980s, it was tracheostomy. That was effective but not terribly satisfactory. Then there was a host of treatments, including surgical treatments, uvulopalatal-pharyngoplasty, and then, of course, nasal continuous positive airway pressure, which is the standard of treatment, or gold standard, if you will, these days. Mandibular advancing devices are also now prominent. But for about 20 years, we had no other treatment option, and we badly needed a treatment option for a disease which, while relatively easy to diagnose, has proven most difficult to treat over the patient's lifetime. And like any chronic disease, you need a treatment which the patient will actually use. The currently available treatment options for sleep apnea do have significant limitations. The primary one is poor tolerance and adherence, and if something works in the laboratory, that's great, but if the patient doesn't use it, it doesn't really work. Also, some of the other non-CPAP treatments have unpredictable or limited efficacy. We have now adequate clinical evidence that documents that nasal expiratory positive airway pressure, the Provent, is a safe and effective treatment for sleep apnea in not everyone, but the majority of individuals, including those intolerant of other treatment options, specifically CPAP. What is Provent? It is those little devices, valves which are adhered to a plaster, which then adheres to the nose. It's indicated for treatment of obstructive sleep apnea. It is FDA cleared. It's a prescription-only medical device. It is disposable, nightly wear, placed over the nostrils, and as I said, held in place by an adhesive plaster. Has an excellent safety profile, as you might imagine. It is interestingly clinically effective for all severities of OSA, although as you will hear, for very, very severe patients, it is not as effective as those in the moderate or mild range. There are now 5 peer-reviewed publications to date, and you'll hear more about that. The latest one published in the April issue of Sleep. How does it work? Well, it works because it is a valve, which is essentially sort of a one-way valve. When you breathe in through the nose, you have unimpeded inspiration. Airflow is normal. When you breathe out, the valve closes and you're breathing out through a small orifice. That creates a back pressure in the airway and ultimately creates a pressure that remains in the airway if it's going to work to end expiration. Exactly how it works, all the methods of its effectiveness, I think we don't fully understand. One thing that seems perfectly clear and must happen, as a matter of fact, is that the lung volume at end expiration has to increase. The FRC has to increase, and this leads to, as we know, a tug on the trachea which decreases the collapsibility of the airway and makes it more resistant to closing. We think that there is also a possible passive dilatation of the upper airway that is carried over to the next inspiration. So as you start to take the next breath, you have a larger airway and thus less resistance and thus less potential for collapse. The last thing that may happen is some patients may develop some hypercapnia, and increased respiratory drive to the upper airway dilators. And another possibility is that it tends to stabilize respiratory control, which could be very important in reducing the frequency of events. This last slide I have just shows a picture of the sham device, which was used in one of our studies, and it shows on the intranasal pressure part, the lower line is intranasal pressure, the upper line is flow, up is inspiration, and you see the pattern of inspiratory flow limitation with chatter from snoring. But the point is that there is the normal end expiratory pause where the pressure in the airway is zero for a considerable portion of expiration or after expiration. With Provent, we eliminate that end expiratory drop in pressure. Pressure remains elevated in the airway for the entire time of expiration, including up to the next inspiration. So at the time of the next inspiration, the airway pressure is positive. That has to lead to an increase in FRC and also suggests that the airway may be significantly dilated at that point. With that kind of brief sort of overview of Provent, I will now turn it over to my friend and colleague, Mayor Krieger.